All right, so we're going to go ahead and get started. I know there are still people upstairs. They'll be wandering on down. But most of the morning, we've been talking a lot about the personal control of health data and why that's important and all the risks associated with it. But we've left one of the most important topics here as the last panel of the morning, primarily to focus on how do we make sure all of this happens. So did it time out? It's okay, it's just the title slide. So what we're going to talk about today, and Dr. Peter Levin, who just recently left as Chief Technology Officer of VA, and he doesn't like me saying this, but as one of the fathers of the Blue Button, or the father of the Blue Button, has done more for personally controlled health data from an implementation and execution and usage perspective than almost anyone else alive has. And so I'm really excited to have him here leading this particular panel about how do we ensure all of the stuff that we just talked about before in the last couple of panels to happen, and that is what is the technology, what are the processes, the procedures, et cetera, to enable that control. And with that, Peter, I'd love for you to take over and go from here.
Thank you, Shahid, for the ever-generous introduction. And welcome to all of you. Very special thanks to my panel members. As a question of format, let me tell you that I'm going to talk for about a minute. And Joy, sitting next to me, is going to talk for about 10. And we're going to leave Ron and Adrian out of the original part of the discussion so that we can get to your questions very, very quickly. So let me try to frame what I think the panel should be about, and then what Ron and Adrian and Joy are going to be able to talk about and share comments and perspective on. So Nathan, in the last panel, told a story that I had never heard before about the illegitimate use of personal health information. I come from a somewhat more sanguine perspective. I'm a little bit more optimistic that in the same way that we drive automobiles even though they're dangerous, and we own guns even though they're dangerous, that we can be, all of us, be trusted with our personal health information. There will, of course, occasionally be bad actors. There will occasionally be criminals who use this information either against us or to exploit us. But from my perspective, we have two choices. We can use data to promote an individual's access to care or work or love, or we can use it to limit data. But by that, we're making, I think, a compromise. A trade space is to not allow public health officials access to it, to not allow insurance companies to help us figure out in a constructive and creative and affirming way to lower our costs. And frankly, we may in fact be constraining, even congesting society's interest to access that data. So on the one hand, we all of us want it. We all of us need it. We all of us by law now are entitled to it. On the other hand, we know that there's an inherent tension in this conversation because the bad people are out there and people who are either not compliant with the law or deliberately breaking it. So that, I think, is really sort of the platform of this discussion. We're going to spend some time talking about rules and regulations and the perspectives that we have. Ron has suggested that we focus his questions and his part of the conversation on the immediacy of access. And are you sure what you're consenting to? So those of us who I would say are forward-leaning, otherwise trusting, signing these forms, most of us without reading them, me among them, do you actually understand where it is that you're taking this conversation? Adrian has suggested that he would like to focus on transaction credentials and patient concurrence. So how do I know you are who you say you are? And very much like Ron, do you understand what it is that you're agreeing to? In the last conversation, I took a note. Adrian was pressing one of the panelists about patient access in Massachusetts. God damn it, I had exactly the same problem in New York City last week. There is a state initiative called the Shiny. If there's anybody here from New York, I would love to bend your ear after this conversation. Exactly the same conversation. The law says you have to, and you're not. Why not? And then last but not least, but most importantly, Joy, who's going to get a lot of airtime, is going to talk to us now about the fair rights of access. So in other words, sort of the positive type, what does the law say about your ability to get your health information, the regulatory frameworks, HIPAA, high-tech, and the CLIA challenges. So Joy, take it away.
Thank you, Peter. And thank you for having me on the panel today. This is one of my favorite topics, as I think everybody knows, about patients' access to their own health information. And one of the things that was very interesting about your introductory remarks was focusing on what you were calling like the bad actors and who use information inappropriately. But there's a flip side of that coin, which is the people who hoard the information from the patient. And that happens still to this day. HIPAA was promulgated, issued a number of years ago, and patients have had a right to request and be able to see and get a copy of their own health information for almost, 14 years now? It should be no surprise to anybody that people have a right of access to their own health information. Yet that still is a major issue for patients trying to get copies of their health records. In the initial set of the HIPAA privacy rule, there was language that patients could request that information in whatever form or format, and that the entities that were holding it were required to give it to them in that format if it was readily producible. There was a lot of discussion over the years about what that actually meant. So when the HITECH Act was enacted in 2009, Congress clarified that that means if you ask for an electronic copy of your health information and it's readily producible, the provider or the plan has to give you your information in an electronic format. So that's really, that made it pretty clear. There's no question about that. There was another change that came about recently, too. And this is really getting into the weeds in HIPAA. So I kind of apologize to the non-lawyers, but I'll try to keep it as high level as possible. So the way HIPAA was originally written, it had what I would call almost a carve out, that patients had access to all this information from healthcare providers. And healthcare providers is defined very broadly as people and organizations that give you treatment or do analysis. So it includes clinical labs. But there was a carve out in HIPAA that referred to another law, which is referred to as the Clinical Laboratory Improvements Act, CLIA for short, as we call it, and that has its own set of regulations. So between those two acts, the net effect of that is there was a carve out. Patients did not have direct access to their lab test results from a lab. Now, some people might say that's not a big deal. You can always get them from your doctor. But there's been research that's shown that about 7% of the time, providers don't even give patients, notify them of their adverse test results. And so we're talking about life here. We're talking about life and death information that people need to act on. So the way those regulations work together is HIPAA defers to CLIA, and CLIA defers to the state CLIA-based laws. So in some states, you were able to get your lab test results directly from, you could ask for them and the lab would give you your lab test results. But in some of these very large states like California and New York, they had very restrictive provisions on when a lab could, if at all, give a patient's access to their own health information. So it took quite a while. I think we did the first study on this when I was on Georgetown, and it was back in, I think, 2009. And this year, 5 years later, HHS released amendments to CLIA and HIPAA to allow patients to get direct access to their lab test results. So the whole big picture of this is now patients have access, a right of access. And that's really important. It's a right. So when you ask, they're supposed to give it to you, a right of access to get their information electronically from their healthcare providers if they're able to produce it. for them. There are very, very limited exceptions to that, about this wide. So that's pretty much the regulatory framework, and I think we're in a pretty good framework now, given all of the devices and apps that are being developed for people, that they will be able to take this information and make it really useful.
Great, thank you. So we wanted to get to questions as quickly as possible. The bios, of course, are in your handouts. If there aren't any questions, I'm perfectly happy to ask a couple, but does anybody want to start us off? Okay, then I will. So, Ron, when you and I were talking briefly, you were explaining that one of the primary problems that you face in this particular topic is that people are, these are my words, not your words, but people are effectively blindly signing their consent away. And then you made the quip, we were thinking that we may have to start Mirandizing people before we put the forms in front of them. Look, Shahid said some outrageously nice things about me, but at the end of the day, I am very interested in giving people access to their personal health information, and I think that they shouldn't have to be lawyers in order to understand what it is that they need to do and what the protections they have by agreeing to accept it. So can you talk a little bit about what the real problem is, and do you have a proposed solution for it?
So we got into this a little bit this morning. It's a very complex problem, by the way. I don't need to tell this audience that. And I'm going to split the world. We drifted into research world this morning a little bit, and it's important to keep research and non-research distinct, but then also recognize that much of the data that's collected for a research study is not research data. And what I mean is that every research study has the objectives of the study. You see, in my world, something like response rate and survival and so on. But the data points that are actually collected are actually commonly collected in many other non-data type situations. So, and then branching over into pathology and tissue world, which has been the subject of a lot of opinions in the last couple years. When the person signs the consent form, which I agree with this morning's comment is usually presented in a rather perfunctory manner, what parts of what are they signing that consent to? And we spent some time this morning talking as if it was the perspective of all data. And then there's the research limited data elements. And then there's the stuff that, as you heard, goes into some de-identified fashion. And the all people want to include that. And there are people who say, no, let's keep that out. So it gets very complicated very quickly as to how many and what data elements are actually involved. I would say probably on any given clinic visit, I may collect, confirm, or ask a few hundred unique to that person. And getting back to the medical record access stuff, where the same concept applies, we did make our medical record basically a carbon copy of it available to patients. Anybody can access it. They see the same things that I see.
Do you call it Blue Button?
It's not downloadable. It's not exportable totally yet. It's quasi-exportable in the sense that they get text files for some of the dictations and so on, and certainly are at full reign to copy those and paste them into whatever they want, including a mining tool that they could mine the word text for different things if they so choose to. But that was a very important concept, to have people have total access. Now, at what time is the other point I wanted to bring up, because in my world, which is cancer world, we deal with those particularly difficult to interpret cancer blood tests, certainly genetic markers, as was mentioned this morning, and other sorts of information like X-ray reports and so on, that that take a certain, we wanted to make sure we were able to have a discussion with the patient before we just unleashed it out there. So after a heck of a lot of discussion internally, we put a 7-day hold on that. It's totally arbitrary. It's not 30 days. It's not 10 days, not 2 days. And that was to give our clinicians an opportunity then to at least review unexpected results with what the patient we knew was going to see in their version of our EMR, so that it didn't come completely unexpected.
Yeah, thank you. Thank you.
Can I comment?
Sure.
We had HHS received a lot of comments from the physician community about that they're concerned that patients getting direct access to their lab test results in particular would interfere with the provider-patient relationship. And the preamble does kind of contemplate that there might be this availability, because under the rule itself, you have 30 days. Legally, you have 30 days to provide it. And so the fact that you're giving it to them within 7 still is a very much less time than legally you're required to do.
I might just say, we thought that was going to open the floodgates for phone calls, and it did not. I mean, actually, it just didn't.
So Adrian, thank you, Ron. So Adrian, I'm gonna put you on the spot. I'm gonna throw you a curveball here. I've been waiting a long time to do this, I have to say. So here's a public health fact. I think you and I would agree to this. That at the very least, we know, I would say with certainty, that 100,000 people die every year in the United States due to avoidable medical errors. From my perspective, that's uncontended. A lot of people think it's more than that. So this is the IOM report. It's a decade old already, so who actually knows? But I don't think that anybody in this room, and I don't think any practicing clinician would argue that it's much lower than that. Many would believe it's higher. Excuse me. So here's the proposition I want to put in front of you. I personally believe that we have grossly overcompensated on the privacy side. I do. One of the conversations that we had when we were launching Blue Button at the VA, and because we had all the conversations that I heard this morning, all the conversations that I read about in preparation, all the conversations that we just heard in Ron's remarks, at the end of the day, it came down to a question of trust. Not do you trust people to comply with the law, but do you trust people to have proper use and utility of their information? And what Secretary Shinseki said at the time was, look, we trusted these people to hold rifles and to fire them in anger in defense of our liberty. And we are not going to give them their health information on a USB stick. That doesn't make sense to me. And that was really the policy inflection, right? It was really the secretary's and the deputy secretary's decision. They went to the general counsel. They went to justice. They spent a lot of time with, talking to the folks at HHS. So from my perspective, we are talking about life and death situations, and I deeply respect and honor the conversation that we heard this morning about all the bad things that can happen. But have we overcompensated? For me, it really is a question. The trade spade is a question of trust and exploitation. Right. What do you think about that?
I think there's another incontrovertible fact of equal or maybe stronger thing, which is that there's $1 trillion of fraud, waste, and abuse built into the U.S. healthcare system. Again, this is Institute of JAMA published facts. I don't think, I think some variation of it has been that number from the Institute of Medicine as well. I'm not entirely sure that the 100,000 number you raised and the $1 trillion that comes from equally reputable sources are entirely unrelated. And the link between them is the lack of quality and the lack of cost transparency that we have in this system. So you can look at privacy in two different ways. I tend to look at it purely from the perspective of fair information practice, which means not consent, but meaningful consent, a meaningful choice to something that you consent to. It means transparency, and it means notice. And I've raised some of those issues in the past couple of days. I can't, you know, I don't know what the alternative is, frankly. The alternative is it's too hard. And, you know, that question came up earlier today, and you just heard it from Ron a second ago. It's too hard. So my question, I would bounce this back actually to Joy in the following sense. You very carefully and clearly established that there is now a right of access, which is what this panel is about. And we also understand that it's claimed to be too hard in many cases. We need to have segmentation. We need to have surveillance that's done based on probabilistic matching because we can't have, you know, voluntary strong IDs. I could go on. Now that we have established that the federal government has established this clear right, and we are still faced 14 years on with the problem that it's too hard, where do we go from here?
I promise I will answer your question, but I like to include a little bit more background information because you raised the fair information practices, and one of the key elements of those, in addition to the notice, the transparency, is the individual's ability to see their information and to correct it or amend it. Yeah. So that is really pretty the core of a lot of where the right of access comes from. It is based in the fair information practices. So I would quibble with you, Peter, that privacy includes that right of access, and that when you're doing that computation, you have to figure that in. And I would also say that when you were talking about unnecessary deaths, that right of access could actually be used to help reduce that number.
Oh, that was my point. I agree with
because as you know, I think it was Geisinger that did the demo project with Robert Wood Johnson's, the Open Notes project, where they had the providers actually, who were very reluctant at first. I was interested to hear what you were saying here. They were very reluctant, but they provided their patients open access to all of their notes, and the providers went very reluctant to do it. And at the end of the grant, when the pilot was over, there was not a single doctor who opted not to provide patients information that way anymore.
Great.
So there you go. It's not that hard.
We have a question. Thank you. That was really insightful.
Chris Burrow. This is a question for Ron. So there are now standards in place, DIRECT and the MU2 standard, which line up and make it technologically relatively simple for MD Anderson, which I presume is using 2014 certified EMR system, and I presume you have it all set up because you're MD Anderson. It's technologically simple to produce a summary medical record, a blue button type record, and to send it securely to a patient's secure email address. And there are plenty of systems out there, HealthVault and others, including our own, the iBlue button system, where patients can receive it. So what do you see as the barrier and the opportunity presented by this new technological development, which is very real? This is not in the future, it's there now.
Yeah. So we actually don't even have to send it anywhere because when it's immediately available at that 72-hour period, or before that even, about 70% of our notes are done within the first 16 hours. It goes right to the patient's inbox on this, what we call MyMD Anderson for Patients. And so it is... Is that a portal? It is a portal. That's not what he was talking. They get an email that there's something new in your portal. They go to the portal, open it up, and it's their record. Yeah.
Yeah. So I'm echoing Peter Schar's comment of yesterday that allowing someone to see a record is great, but the issue here is allowing the patient to own the digital data and receive it on their own system so that they will then have it and can share it with others. So I'm just wondering, and I'm not trying to put you on the spot.
No.
Yes, I am. But
that's okay.
But this is really a question for the entire galaxy of provider organizations, and I trained at Baylor think highly of MD Anderson, and I'm really interested in your perspective on that.
So the answer, the other part, the reason why I laughed when you asked the question was, and I think this is part of the reason why stage 1 is being extended just a little bit, is we in particular are moving our EHR from the one we built to a very large commercial product. So no, we have got an extension for stage 2 for exactly that purpose. But there's the technical aspects of things like you bring up. And I would say the most important part is really the philosophical part of it. Unless an organization makes the commitment that what you said is true, that this is a shared record that everybody should have access to, and it should be as quickly and immediately as possible. Unless you do that, the technical aspects don't have a chance of coming in play.
I'm going to take moderator prerogative here and very briefly respond to that. I think you mean policy-based access, right? We're not talking about unfettered access. And the short and most compact answer I can give to any technological impediment, whether it's at MD Anderson or at Veterans Affairs or any national health delivery network, is horse feathers. This is an extraordinarily straightforward, easily accomplished, plenty of precedent. There may be philosophical issues, there may be policy issues, there may be regulatory, legal, or even clinical issues. I can think of mental health exceptions that we need to talk about. But people are letting the tail wag the dog on this. This is not a technological problem at all.
Thank you. My question is for Joy. First part of the question is, are the health information exchanges like the ones we heard about yesterday in Delaware and Indiana covered entities under HIPAA?
As a general rule, health information exchange organizations are business associates of covered entities. They are set up to provide so whenever you ask a question like this, it's great to go through this. Do they provide health care directly to the patient? No. Are they a health plan? Most of them, I would say no. Now, there may be facts that would bring somebody within that, but for the most part, they're not healthcare providers and they're not health plans. Healthcare clearinghouses, people think that they might be that, but if you look at the definition in HIPAA, it's a very narrow definition, and most of them do not perform those kinds of services. They are not, and they're not covered entities. They are business associates.
But as a business associate, we heard the woman from IMS Health this morning tell us that they consider themselves just an extension of the company that generated and owns the identified data that they're performing useful data analysis on. I'm asking this question because it's become clear in the last 2 days that a big problem with the blue button is you can get perhaps one set of records from one provider in one format, and if you have more providers and you keep going and you're successful, you'll end up with records in formats that still need integration in some way for you to usefully take them to your next provider. And it seems the integration puzzle has been solved by the HIEs that are collecting EMRs, clinical records, billing records, and putting them in that mega file. That's where I'd like my blue button to take me. First of all, I don't even know which of these exchanges has my interconnected set, but could you guys talk about if a policy question has been raised yet about whether we'll get a blue button access to that?
Why don't you take it first?
Yes, and stand by. There was an announcement at the beginning of the week on exactly what you just described. There were some missing software architectural components, very simple ones, by the way, that are now publicly available in the open source. And the number of people, it's a feeding frenzy at the moment, just people who are downloading it, looking at it, and answering exactly the question. This was a well-known, well-understood gap in the use model. I think you've said it extremely well. What may or may not be well-known, it just got announced during the Datapalooza, is that it's available.
Will you push to individuals the identity of the exchanges that have their data?
Yeah, we can set that up. Please.
So I'd like to add my 2 cents on this one. So we recognize that was an issue, and if you look back at the request for information that HHS released for its governance of health information exchange, that question was raised, and the response we got was quite interesting. Let me put it that way. It was not supportive. And what this demonstrates once again is that if there is a notice of proposed rulemaking or an ANPRM, and you support something that's in that, if you don't submit comments that say we support this, I can guarantee you everybody who doesn't like it will be submitting comments, and that's all we have on the record.
Really good point. Really good point.
Scott Mays with Health Leaders. I think a very important missing signatory to the Blue Button Pledge is Epic. I don't know whether Epic is what you're transitioning to, Ron, but I think that we need somehow to get past their unwillingness to, number one, take the pledge, and number two, take these new pieces that you're describing and actually implement that, because until that's in code, a lot of this is not going to matter to millions of Americans whose records are stored in Epic.
Yeah.
The fact that Epic is missing from the Blue Button Pledge is well known, and we have laws about that now.
Can you elaborate?
Patients have viewable, downloadable, and transferable rights to their electronic information.
Are you suggesting that patients should be bringing suit against
I'm
someone?
I'm stating that Epic does not support the Blue Button, and I'm also similarly stating that we have a law that says that every patient has right to their health information.
So since I'm sitting here, I have to say that I want to make really clear that the law says that the patient has to, the law says the patient has a right of access. MU, meaningful use incentive payments, are considered voluntary. Yeah. And there is a very, and there are all kinds of things that, conditions that go along with that. So I think that saying that Blue Button is a voluntary effort, MU is a voluntary effort, we're doing as much as we can to incentivize people to do things in a uniform way. The HIPAA privacy rule does not require people to use these specific standards or ways of making the information interchangeable.
And could I just interject? That's why I used the words I did before. It's more of a organizational and philosophical decision, because we know that a lot of people are bailing out of meaningful use and choosing not to do it, and choosing not to take the voluntary aspects, choosing maybe even not to participate in the Medicare program. And so, you know, it's above that. You have to decide it's important as an organization, that is a shared vision, that you and your patient are collaborators in the delivery of care.
And I would suggest that the patients have to be very much vocal and, you know, demand not only that you, but the vendors and everyone provide view, download, and transmit in a form they can use.
Yes.
That's my point.
I'm confused here.
Yeah, I'm confused. I'm sorry.
I'm genuinely confused. I'm going to go back to the question I tried to ask before, as to how do we interpret a right under as we have it now. The first thing you said, Joy, was that it's a right.
Yes.
The last thing you said was that some aspects of the regulations as they stand now are voluntary. Scott asked.
That's not exactly what I said.
Well,
I didn't say HIPAA was voluntary. HIPAA's not voluntary. High-tech amendments to HIPAA are not voluntary. MU, to receive payments under MU is voluntary. And to participate, there's nothing in HIPAA that expressly tells people they have to use Blue Button. So the question, it was a very nuanced question. The answer to the question is very nuanced, is the way I would put it. We have done, and I think through meaningful use and through the Blue Button Initiative, and we have done a lot of work in trying to encourage people to do things in a uniform manner. And the absolute the right is to get it in an electronic form. The right under HIPAA is not to get it in a standardized format. So you have to look at all of these different levers that you might have. I wish it was simpler, and I wish it, I think everybody wishes it was stronger, but ultimately, as you were saying, people can elect not to do MU if they don't want to.
But again, I'm trying to understand the right. How for instance, would MD Anderson be connected to this right? I didn't use the term meaningful use at all.
Or Blue Button, for that matter.
Or any particular Blue Button or any other particular best practice. Or uniformity even. I think we have an opportunity here between the four of us to try and elucidate the answer to Scott's question, or my question, where do we go from here? Is it now a question of patients bringing suit, or is it a question that industry will voluntarily deal with this right in a particular way?
So since a piece of that was directed to us, I will tell you there's been a great deal of discussion, given the vendor that was named earlier and given our decision to go with that vendor, whether to use their non-methodology for doing that or whether to continue to develop our own and make sure that we are fulfilling exactly what we believe in doing, or, as we said, signing up with them and then taking what we get.
I'm sorry. So what?
I'm sorry. We're running out of time, and there are two more questions.
I'll try and be very quickly because it's turning out that I may not be as controversial as I'd like to be. But I just want to speak very briefly to it's too hard. Yesterday morning, Sahid was talking about the fact that it's difficult to add the kinds of features and protections to software that we want because they weren't part of the original requirements. And they weren't part of the original requirements because we aren't the customers for anyone in the system as it exists today. It's certainly not too hard. It is hard. I'll have to disagree with you some, Peter. It's going to be hard to do, but it's not technically hard. It's just going to be a lot of work. It's going to take money. It's going to take prioritization. So I just want to suggest, if we are not literally the customer and can't say, I won't buy it or I won't pay for this until, we've got to go out and sue and push and be a massive pain in the ass to the people who have to make the decision that this is going to be hard, but we're going to do it anyway.
So could I just respond to that just a second, what I meant by that? And so I'm taking this only as a patient, because I guarantee everybody in this room has been a patient at least once in their life. Depending on the level of the detail, okay, so the either or, the 100% or no, that's easy. I don't know exactly, and sometime we can philosophize about how many times a day some piece of my medical information is being queried by someone. I mean, if you're really a little paranoid, that could be a lot of times a day. And the technical part is, do I want to get an email, in some secure email in every format, every time that occurs, to respond to someone wants to use your LDH that you had done in 2007? That's obviously one extreme of the question at hand, and the database of who maintains all that accurate information, so I'm not getting an email that was my email like 4 years ago and maybe someone else has that, or maybe I'm not around, all those sorts of things. Is it doable? Of course it's doable. It is extremely complicated. And then there's my side of things. How many emails a day do I want about my PHI anyway? I'm just looking at it from a user of the system.
Great comments. Bettina.
So, Bettina Experton from Umetrics, but as a patient, also as a former practicing oncologist, what HHS has achieved with the new HIPAA rule and CLIA is absolutely transformative for the safety of millions of Americans today. And with the Blue Button initiative, which Peter Levin has championed at the VA, you do have today the standards which meet the meaningful use, view, and download transmit standards. And you do have the tools for me, the patient, to assemble on my application, on my device, or my application on my PC, all those various Blue Button or otherwise CCD record coming even from an EPIC system, so that I can assemble all that information in a meaningful way, take a with my application, iBlue button takes one tap of a button securely on my own device. We do all the transformation, all the aggregation, all the normalization, because we work with standards. And it's transformative. Everyone can use those tools today. The word has to be out. This is about life and death, as you say so well, Joy. Thank you.
Well, we are standing between you and your lunch. Thank you very much for the panelists. I personally don't like boring panels, and I don't think that this one was especially calm, which is great. Thank you all for your terrific questions, and let's also thank Shahid for moderating. I'm honored from here.
Thank you for moderating it.
Thank you.
So, as a consummate professional, Peter got us back on time. That's great. So we have lunch starting at the Hyatt, same place we had the dinner last night. Please don't forget that we'd like for you to fill out the surveys for the conference, and Deb will say a few closing remarks.
Well, the first thing I would like to do is recognize Larry. Larry has been doing all of the incredible accommodation to our speakers and with the lights and video recording. And Larry, you are absolutely brilliant, and we could never have done this without you. So everybody wave at Larry. Thank you. Thank you so much. Okay, so you don't want to miss this lunch, because Adam Tanner is really a spectacular investigative reporter, and you're going to very much enjoy what he has to teach us about re-identification. And so, see you in a few minutes. Thank you.
Thank you.
Thank you all.